And so we are back. This time it is my pleasure to have two of the foremost experts in the world on neuropathy with me here in the studio. Yesterday you were discussing with Professor Claudia Sommer neuropathy, and it was a debate, so you both, all three of you, gave aspects, your personal aspect on neuropathy, and you were teasing each other a little bit about your methods being the best.
May I say something?
Of course you may.
It's not neuropathy, it's neuropathic pain.
So now that we are at it, what is the difference?
Neuropathy is a lesion of nerve, with neuropathic pain is pain due to this lesion.
See, that I knew that, but thank you for correcting it. So, and whilst we're at it, now we have hijacked everything, haven't we? So, would you mind, Ralf, would you mind explaining to the listeners who you are and why you are here?
Well, so my name is Ralf and I'm a professor of neurology, and I'm a pain doctor, pain specialist, as well as a neurologist. I think I'm also a neurologist. So, and I'm working in Kiel in Germany at the university hospital there. And I'm leading a department on pain therapy and research. So from this, you know that I'm seeing patients, a lot of patients. It's all the pain patients, not just patients with neuropathic pain, but also others. And we are involved in lots of research as well. So we are interested in the mechanisms of the generation of pain. We are interested in subgroups of patients who perhaps perceive their pain differently.
And I assume during our talk today you're going to mention QST, quantitative sensory measures?
Well, this is one of our hobbies, if I may say so. So the sensory testing with specific machines and test procedures we perform every day. And this is called quantitative sensory testing, yes.
And so you look into the German network type thing, and you are co-authoring that. And just coming over to you, Didier, you've done some DNIC work as well, which is that dynamic aspect of the descending modulatory system. You were telling me your PhD was on with Lebas?
Yes, my PhD long time ago, yes, was on diffuse noxious inhibitory controls, NIC. So this system is a system of descending modulation of pain by the brain. And yes, I did my PhD on this in animal models, actually. And so then I moved back.
If nothing else, you have that in common.
Oh, we have many things in common.
We have many things in common. So it's not like yesterday with the debate in real life. You know.
So I should give you time to explain to the listeners, of course, who you are and what your background is.
So I'm also a neurologist by training and a pain specialist. I've been trained in Paris, and I'm still working in Paris in a pain clinic, so meaning that I see patients with neuropathic pain, but not only neuropathic pain. I see all kinds of chronic pain syndromes. And as Ralf, I'm also largely involved in clinical research. I'm the head of the special group related to clinical research on pain. And this group is funded by INSERM. INSERM is the National Institute for Research in France, medical research in France. And we've been largely involved over the last 25 years in various aspects of clinical research in neuropathic pain, but not only neuropathic pain. We have also done some work on other types of chronic pain, including fibromyalgia, abdominal pain, visceral pain, etc.
And just like Ralf has a special interest in the QST, you have a special interest in questionnaires.
Yes. I have a special interest in questionnaires. Yes, we have developed and validated several questionnaires related to the screening, detection, and assessment, measurement of neuropathic pain, but also questionnaires for fibromyalgia and osteoarthritis pain. But we are mostly recognized for our work on these questionnaires on neuropathic pain.
And that would particularly be the DN4. which is
The DN4, yes,
is-
it was developed by my group some 20 years ago now, and it is a screening tool, meaning that using this very simple tool, questionnaire, asking questions to patients, you should be able to identify with a high probability neuropathic pain, recognize neuropathic pain among other types of pain. Because one issue at that time was that, and it is still the case actually, neuropathic pain is not sufficiently recognized by non-pain specialists or non-neurologists. And so we thought that it would be important to develop a very simple clinical tool that could be used by anyone to better detect, screen this pain.
And I guess it's interesting here to bring in the historical perspective, because back in the 1990s, everything that was pain in the leg or pain in the arm was neurogenic pain or neuropathic pain. So many names came about, and I think this is where the first mechanistic descriptor, neuropathic pain, as it were, came out, because there was this understanding that there was a certain mechanism, the injury, the insult to the nervous system, that led to the pain, hence neuropathic pain and not neuropathy.
But I think it was even worse. When in my medical studies, there was no distinction between neurogenic or neuropathic pain and nociceptive pain whatsoever. So everything was pain.
Everything is
and
pain.
everything was treated the same. And I think this is a really advantage in research and in clinical research, that we now clearly can identify these patients, and due to several screening tools, for example, because we have to treat them differently, and this is, I think, a major.
Before
major
treating them, you have to
advantage.
identify them.
Yeah.
So,
And I guess this is the pivot, the idea behind mechanism-based treatment, isn't it? It's finding out what is driving the pain.
Well, I think one
is
is screening to identify the type of pain, and the term mechanism-based treatment is to identify a certain underlying mechanism of the generation of pain, to perhaps establish a personalized treatment approach in the future. And this is what we are not now doing with quantitative sensory testing, but also with questionnaires as well. And we have some positive results that clearly show that it's possible to subgroup patients. Not every pain patient, neuropathic pain patient, is the same.
Yeah.
And so we have to show that they are different.
So may I ask, how do you feel with the whole German protocol? How do you feel about the Neupzig algorithm for absolute or definite and possible neuropathic pain? Do you think they correlate, or is one different from the other? Are you finding different things?
Well, I think these are different things. So the algorithm is to find the clear diagnosis of neuropathic pain due to the different steps you mentioned. So screening tools screen, and then you have to use the algorithm to find the exact diagnosis. DFNS might be one part in this algorithm to identify sensory abnormalities, for example, and therefore you can use it within the algorithm.
but it's the algorithm, the Neupzig algorithm, has been regarded as an improvement, because it gave the researchers strict criteria to include patients in clinical trials or in other types of studies. But this is mostly used for research, actually. It's difficult to use it not for us, not for neurologists, but for non-neurologists. You need to have a neurological background to use this algorithm. That's why it is not that much used in clinical practice, besides pain specialists or neurologists. But it is extremely useful, because it's a way to standardize the criteria for identifying, selecting the patients, especially in clinical research. So this is one of the major progress that we got in the last 15-20 years.
And I guess you almost said this, but I just want to clarify. So what you are saying is that if we identify the subgroup of people with a neuropathic injury or neuropathy who also have pain, then their treatment would be significantly different from if they did not have a neuropathic component to their pain. Is that correct?
Yeah, that is absolutely correct, because we have learned that the classical analgesics do not work in neuropathic pain states, so we have to avoid them. And therefore, we use entirely different
So by classic analgesics, you refer to opioids?
No, opioids, non-steroidals is what I'm referring to. Yeah.
So the group of, let's just have that. So the group of medicines you would use for neuropathies or neuropathic pains, as it were, would be
antidepressants or anticonvulsants,
Yeah.
anti-epileptics. These two classes of drugs are the first-line treatment. Not all the antidepressants and not all the anticonvulsants, but some of them are the first-line treatment for these patients. And as Ralf said, the classical analgesics do not work very well or not at all in these patients. And so the issue is to try to improve, because even using these classes of drugs, which were not developed for pain treatment at the beginning, of course, and using this first-line treatment, the treatment outcome is not that good. We have less than 50% of the patients who got a partial reduction in pain intensity. So that's why we have a lot of work to do in terms of clinical research and trying to improve this. And one way to improve this is to recognize, to acknowledge that these patients are highly heterogeneous in terms of their clinical presentation. They don't have the same symptoms, they don't have the same signs, they don't use the same words to describe their pain. And our idea is that probably this reflects different mechanisms and therefore different response to treatment. And all the work we are doing with the QST, with the questionnaires, with all the way we could find to classify, to subcategorize the patients is in order to better personalize the treatment approach. Because we know that there is no treatment for everybody. So antidepressant or anticonvulsant do not work in all the patients. So we have to try to find a way to identify the best responders.
So we have to realize that all the clinical trials which are available at the moment use the entire group of patients with, let's say, diabetic painful neuropathy. And it's an average, and we look for averages, for pain reduction in the entire cohort. And because, as Didier mentioned, patients are so heterogeneous, so we have to identify subgroups, and we could identify subgroups who really benefit from the treatment, although others do not. And on average, there might be a zero, no pain reduction, but some of our patients benefit enormously.
I think that's being a bit crude, isn't it? There is an effect. I mean, no matter what you look at, there is an effect, isn't there? I mean, again, I know more about musculoskeletal pain. I haven't seen neuropathic pain patients, as not a lot anyways. But what you see in studies is that if you look at back pain, for instance, seems like everything has an effect, as long as there's a therapeutic involvement, for instance.
Of course, this is not a specific effect. So we all know that there is this non-specific placebo effects related due to the relationship between patients and therapeutic alliance, as we say. So of course this is always present. So we always have an effect. But what we want is to improve this effect, to get more than this, and to have a rational way to identify the potential responders. Because as Ralf said, with all these classes of drugs that we are using in these patients, we know that they are very good responders, but we know this afterwards.
Only once they've done it.
Yes, exactly.
Correct.
That's after the fact.
We have to define them prospectively, and this is the work we are doing at the moment.
Well, that's interesting, first of all, because again, I've always heard that people with neuropathic pain are notoriously difficult to treat. And they suffer more than people without neuropathic pain when you compare them, again, on a very, very crude level.
I think that's correct. If you use Pain Detect or DN4, these screening tools in cohorts of patients, and compare the positive ones and the negative one, all the positive ones, so the neuropathic component patients, have quality of life issues, sleeping problems, much, much worse than the other
And
groups.
this has been clearly demonstrated
Yes.
in several epidemiological surveys in France, in many countries, and clearly the neuropathic components by itself, independently of the intensity of pain, the severity of pain, the chronicity of pain, the duration of pain, the presence of neuropathic components that we can detect with these screening tools, for example, is predictive of a much higher impact on quality of life in these patients.
It's interesting, and I hope you'll excuse me for being hopefully not ignorant, but not by any means an expert in the area. And I was reflecting on your debate yesterday, and this may be you first, and I would be happy for you to chip in as well. So we use these questionnaires, the DN4, and one of the things the patients rate is how they experience the pain. My understanding is that may be based on the McGill pain questionnaire. I don't know if
No, thanks. It's different, but it's the same principles.
Yeah.
But it's different. The commonalities with the McGill pain questionnaire is that we use words, descriptors, pain descriptors,
Yeah.
and we ask the patients to describe their pain, actually.
And I guess my reflection is do we know? I like the fact that we ask the patients. I think that's something we are getting much more back to and doing much more than we usually did. But do we know that when the patient, for instance, says, I have this kind of pain, and then we give them what we think is the appropriate treatment, does that change? Or even if it changes, does it lead to more quality of life? Do you understand my question?
I understand the question. You have a problem with the subjectivity of the descriptors. Actually, clearly we know that's been clearly validated in many studies in many languages, with different screening tools. For example, the DN4, the Pain Detect, other screening tools, which are all based on pain description. We just ask the patients, is your pain like burning, electric shocks, etc., tingling, etc., and usually these terms were regarded as too subjective, too culturally dependent. And actually, this was quite a surprise for us, is we showed that the presence of this term, not one, you have to have several combinations of several terms used by the patients, then you have a very high probability of having a neuropathic pain. This was shown not only in French, in English, in German, but in more than 80 languages over the world. So meaning that there is a kind of relationship between the language, the very words used by the patients, and probably the mechanisms of neuropathic pain. So that meaning that the language of neuropathic pain is not that subjective.
So I guess this
That's
is
one word to your question. So if you develop a questionnaire, and we develop this, you always have to include patients. And you have to present the descriptors to the patients which you think is important. And then they have to judge, is that correct? Is this my feeling? Is this the best expression for my feeling? And it's interesting, sometimes the patients don't understand the descriptors we chose and say, you have to change this and this and this. But all these validation steps include patients, and I think this is very important.
If I get it right, then so you do the screening, and then you see there's a possibility for someone to have a neuropathic pain here, and then you send them off to a neurologist or someone else who is qualified to go through the Neupzig algorithm. Is that how it's?
Yeah. This is the first step, is screening, then confirmation of the diagnosis, and then treatment, management, of course. Yes.
So let's imagine that everyone could follow and had the skills and the attention to follow the Neupzig guideline. Would the questionnaires be rudimentary then?
The questionnaires actually could be included in this algorithm, but at the very beginning, they are screening tools, so it's a sign that there is something probably neuropathic, and then you have to apply the classical clinical approach to confirm.
But they're not part of the algorithm as it is they?
They are not official. No, officially they are not part of the algorithm, but it is mentioned in the paper that they could be used at the very beginning to enter in this.
But again, it's something different. The questionnaires we develop are for screening, and this is mainly for GPs to screen
Yeah.
for neuropathic pain. The other is an algorithm for specialists to go through to find the correct
I guess what I'm trying to
diagnosis.
build up here is that does it, again, this false assumption that everyone could follow the algorithm and they were paying attention and it was easy to do in the GP's office.
Okay.
Would it add anything more? It's coming back to the question. I like the fact that we ask the patient, does the patient's verbal expression give us any insights to what treatment? So
Yes.
if you do the algorithm, does it give us anything extra to have the questionnaire that will help direct treatment?
Yes,
or-
that was our debate yesterday, because you can also use questionnaires to measure pain, not only to screen, but to measure the different components of neuropathic pain. And it's also the same principles. It's based on pain descriptors, burning, electric shock. But in that case, you don't ask the patient, do you have burning, yes or no? But please rate your burning pain between 0 to 10.
Yeah.
Okay? And actually, using this kind of rating, really based on the patient's descriptions, the idea is that we should be able to identify subgroups of patients which will respond differently to the treatment.
Yeah.
So using the descriptors to define the treatment of the patients. So this is still research, of course, but this is exactly the idea.
Yeah.
And
So moving it from a screening tool to actually an outcome measure.
Well, but if you use the algorithm, I think you can gain a little bit of precision in finding the diagnosis, and therefore this is for research purposes enormously important, because you have to find exactly the right patients with neuropathic pain. But
Yeah.
if it comes to screening and treatment,
Yeah.
it's, I think, better to find some more patients and treat them adequately.
And I know you're both very busy, so I won't take too much of your time, although I think this is really interesting. I have one question, and you probably can't give me a definitive answer for that, but I would hate myself for not asking this. So, in my understanding, and we sort of talked about it, so I assume you would agree, a person has an insult to the nervous system, that be pathological or traumatic, and then they develop a neuropathy. And I think, roughly speaking, 2 out of 10 with a neuropathy develops to have chronic pain or neuropathic pain. Again, very different.
depends.
Amputees much more and some much less, but there's
On
only a
average, it's
subgroup
fine,
who
yeah.
develop neuropathic pain. So my question is, in your minds, do you think that the neuropathy is all the way with over the next, let's say, 10 years or however long, is that cause the pain they experience and the disability related to that? Could they be treated if we could treat the neuron? Or are things now getting so complex that, as a matter of fact, that's where it started, but now it's cascading into a neuroimmune whatever? I don't know if that's
so
even a question, but
It's a very good
It's a
question.
very good question. I believe that if you really would be able to regenerate the nerve so that the nerve is really absolutely intact like before, then you don't have any pain anymore.
is that I mean, look at the mirror. I mean, we live a new day every day, but we are never the same. So the nerves would never be the same. They would have to be age relevant, wouldn't they?
Well,
yes, but that is
yeah.
physiologically it is recovering. But you know, even this is just Ralph's opinion.
Yeah.
We don't know actually.
We don't know.
We don't know. And many people do think that even if you treat the nerve injury, it might not be very effective on pain, because pain is mostly related to central changes in the spinal cord, in the brain. But at the moment, we still do not have a clear answer to this very major question. We don't know if just treating the nerve will be enough.
And this is because we don't have any tools to induce complete recovery of the nerves at the moment.
But I know there are, and there's probably much more than I've ever read about. So using, for instance, lidocaine on stump pain with amputees, and that helps in some and not in everyone. So are we back to the old argument about phenotypes, different
Exactly,
types of?
perhaps, yes, we don't know. But it is possible that in some patients the peripheral mechanisms are still very important, And so if you find a way to treat them, you should cure the patient. And perhaps it is likely that in other patients it's completely different. And then the periphery was an initiate the process, and then the central changes in the spinal cord, in the brain, are autonomous then. And then even if you treat the periphery, you won't get anything. But this is completely speculative, we don't know.
No. So, okay, let's put it very dichotomously. If you could choose to cure the nervous system and maybe the patient gets better, or if you could treat the patient and maybe the pain has to be there, but the patient is still functional, they can live their lives and sleep their sleep, what would you go for? Would you go for treating the nervous system and hoping for the best for the person? Or would you go straight for the symptom and maybe they have to live with the pain? What do you think?
We'll try both, obviously.
No reason to be restrictive.
No.
So if
that's probably the best answer.
If you ask me as a researcher, I would go for the regeneration part.
Yeah.
If you ask me as a clinician, I will go for the symptom part.
Well, I think that's a nice ending. So I want to thank you for your time. I know you're very, very busy on a conference like this. Thank you for your contribution yesterday, and thank you so much for joining us today.
Thank you.